Now let's discuss gastritis. Gastritis is any condition with inflammation of the mucosa. There are two main categories, acute and chronic. You're probably more familiar with chronic gastritis, which is more common, so you may think all gastritis is non-erosive. However, acute gastritis can occur, and when it does, it is actually erosive. Many patients develop acute gastritis, often simply referred to as stress ulcers, and there are two named versions. The first is Curling's ulcer, related to burn injuries, and the second is a Cushing's ulcer, related to brain injuries. The other main causes are severe stress, as we mentioned, NSAIDs, alcohol, and uremia. The mechanisms of each are slightly different. In a patient taking too many NSAIDs, the drugs block production of prostaglandin E2, which is necessary to protect the gastric mucosa. In the Curling's ulcers, the loss of plasma volume related to the burn can by itself cause sloughing of the gastric mucosa. In brain injuries, patients may have an increased vagal stimulation, which leads to more acid production by high levels of acetylcholine, causing the Cushing's ulcer. For this reason, most ICU patients are given proton pump inhibitors as part of their daily meds. The mnemonic that may help you remember the difference is being burned by the curling iron and always cushion the brain. Now let's mention the more usual chronic gastritis. Type A occurs in the fundus and/or body of the stomach, while Type B occurs in the antrum. Type A happens to be caused by a number of conditions that start with A: autoantibodies to parietal cells, pernicious anemia, and achlorhydria. A mnemonic that may help you remember is AB pairing. Pernicious anemia affects the gastric body. Type B, affecting the antrum, is really the most common form of gastritis. It's caused by the bacterium H. pylori and is generally easy to treat with combination antibiotic regimens. If it's untreated, there's an increased risk of malt lymphoma. The mnemonic here is just the reverse. The B, bacterium, affects the A, antrum. Interestingly, those that go on to develop malt lymphoma can potentially see an improvement in their symptoms and their cancer if they receive antibiotic therapy to eradicate H. pylori. Imagine that, antibiotics that help cure cancer. Now, just a brief mention of Menetrier's disease. This is a condition of gastric hypertrophy that has protein loss, parietal cell atrophy, and an increase in the number of mucous cells as its primary features. Another important thing to keep in mind is that it's precancerous. The rugae of the stomach are so hypertrophied that they are described as looking like the gyri of the brain. It's a rare form of gastritis, and it's not heavily tested, but it's good to keep the characteristic image in your mind. Stomach cancer is almost always adenocarcinoma. It's an aggressive tumor that spreads locally early on and frequently metastasizes to lymph nodes in the liver. Some common associations are smoked foods, achlorhydria, chronic gastritis, and type A blood. Microscopically, you may find signet ring cells, which are pictured here, and on gross histology, you may find linitis plastica, which is a thickened, rigid appearance of the stomach lining. The first sign of disease may actually be acanthosis nigricans, which is a grayish-brown discoloration of skin regions, notably the axilla and the neck. An important epidemiological point you might want to keep in mind is that this type of cancer, gastric cancer, is much more common in Japan than in the US. Some frequently tested facts are the Virchow's node, which is the left supraclavicular node that may be the first sign of the disease. This is because the cancer spreads to the lymphatic system from the stomach and drains into the thoracic duct, which ends in the venous system at this location. The Krukenberg's tumor is when stomach cancer metastasizes to the ovaries. Finally, the Sister Mary Joseph nodule near the umbilicus is another common location for METs. Peptic ulcer disease involves an actual erosion of the GI lining. Whereas gastritis is inflammation of the mucosa, peptic ulcer disease is a true erosion of tissue. The two forms we'll mention are gastric ulcer and duodenal ulcer. In gastric ulcers, the pain is greater with meals, G for greater, and in duodenal ulcers, the pain is actually decreased with meals, D for decrease. Because gastric ulcers have greater pain with meals, people typically begin to eat less and thus lose weight. It's common in older patients. H. pylori is commonly involved in around 70% of cases, but chronic NSAID use is also an important factor. These patients have a positive urease breath test. Duodenal ulcers have decreased pain with meals, so these patients often gain weight. Although most of the gastric ulcers are related to H. pylori, nearly 100% of the duodenal ulcers are related to H. pylori. The effect of this organism is reduced mucosal protection, which allows the normal acid load to harm the stomach lining. Occasionally, however, duodenal ulcers are caused also by Zollinger-Ellison syndrome, the gastronoma, in which case the acid load just overwhelms the normal mucosal barrier. Suspect Zollinger-Ellison syndrome is especially in question if you see an ulcer extremely far down the GI tract. Ulcers tend to have clean, punched-out margins, which makes them very obviously different from the raised and irregular margins of stomach adenocarcinoma. The major complications include bleeding, penetration into the pancreas, perforation, and obstruction. Ulcers, along with esophageal varices, are the most common causes of upper GI bleeds. To round out this discussion, it's important to note that the standard treatment for peptic ulcers is known commonly as triple therapy, involving a PPI, the antibiotic clarithromycin, and another antibiotic, amoxicillin. You can use metronidazole if a patient is allergic to penicillin, which would also make them allergic to amoxicillin. If you give them metronidazole, do you remember what substance the patient can't ingest while on the drug? That's right, ethanol. Aside from the possible cancer risks that we discussed earlier, there are other possible complications of ulcers that you should be aware of. The first is hemorrhage, which most commonly happens when gastric ulcers erode posteriorly into the gastroduodenal arteries. The other complication is perforation, which happens most commonly in duodenal ulcers, usually when they erode anteriorly. Okay, we'll talk for a while about inflammatory bowel disease now. We're going to compare and contrast Crohn's disease with ulcerative colitis, also known as UC, so that you can identify which of the diseases your questions are asking about. Both Crohn's and UC are potential causes of a lower GI bleed. In both diseases, the etiology is incompletely understood. Crohn's is thought to be related to a disordered response to intestinal bacteria, and UC is an autoimmune disease. If you remember nothing else about these two, please remember that Crohn's disease can involve absolutely any portion of the GI tract, from the lips down to the large intestine. Ulcerative colitis, on the other hand, is strictly limited to the colon, so there's kind of a clue in the name. Absolutely critical. That being said, the terminal ileum and colon are the most commonly affected regions in Crohn's disease, so you can't diagnose one or the other solely based on location. Crohn's disease also has skip lesions, meaning that you can have an affected area, then a normal area, and then another affected area. This is another really important feature of Crohn's disease. The rectal area is spared, whereas in UC the rectal area is always involved. Okay, so on to the pathological features. Here we've got some full-color images for you. In Crohn's disease you have transmural inflammation, meaning all layers are involved. In UC, only the mucosa and submucosa are involved in the inflammation. This means that in Crohn's you can have perforations and fistulas that would never occur in ulcerative colitis. Crohn's also has the features of cobblestone mucosa, creeping fat, bowel wall thickening, such as string sign, and fissures and fistulas. You also see linear ulcers. In ulcerative colitis you find pseudopolyps, with freely hanging mesentery, and the inflammation causes a loss of haustra, which eventually gives the lead pipe appearance on imaging. Microscopically, these are also quite different. Crohn's has non-caseating granulomas. UC does not have granulomas, but it does show crypt abscesses, as well as ulcers and bleeding. So let's reiterate just a little bit about the microscopic morphology. As mentioned before, look for non-caseating granulomas in descriptions of Crohn's disease, and in UC, look for crypt abscesses. Another important feature to keep in mind is that in Crohn's disease a lot of the findings are Th1 mediated, whereas in ulcerative colitis they're Th2 mediated. In terms of the major sources of morbidity and mortality, strictures, fistulas, perianal disease, malabsorption, and nutritional depletion are often seen in Crohn's disease. Something else to keep in mind is that you do see a higher rate of colorectal cancer in Crohn's disease than in the normal population, but you see a much higher rate of colorectal cancer in ulcerative colitis. UC similarly has malnutrition and another devastating complication known as toxic megacolon. Both certainly have diarrhea, and in Crohn's it may or may not be bloody, but in UC it's always bloody. There are also extraintestinal manifestations. Patients with Crohn's may have migratory polyarthritis, erythema nodosum, ankylosing spondylitis, uveitis, or other immunologic disorders. Patients with UC have pyoderma gangrenosum, or primary sclerosing cholangitis. Treatment for Crohn's consists of corticosteroids and infliximab. UC treatment options include sulfasalazine, 6-MP, and infliximab. Prophylactic colectomy is usually performed due to the extremely high risk for cancer. A mnemonic that might help you organize your thinking about Crohn's is a fat granny and an old crone skipping down a cobblestone road away from the wreck.
Alright, let's try to keep the terminology straight. We just talked about Crohn's and UC, which are inflammatory bowel diseases, or IBD. Now we'll talk about IBS, which is irritable bowel syndrome. IBD is inflammatory, IBS is irritable. The primary symptom of IBS is recurrent abdominal pain, and the other features include improvement of pain with defecation, change in stool frequency, and change in appearance of stool. Patients may have diarrhea, but they may also have constipation, or both. The symptoms are chronic, and there are no structural abnormalities to look for. Pathophysiology is multifaceted, which in some cases means there's a large psychiatric component. The goal here is really symptom control. You can often think of the disease in cases where there are no red flag symptoms, such as rectal bleeding, tenesmus, weight loss, greasy stools, etc., and the patient has alternating constipation and diarrhea. Look for this in patients that have GI symptoms that fit this profile and are also undergoing a large amount of psychological stress.